Hello, good evening from the United Kingdom, and good morning and good afternoon from around the world as we are on OrthoTV Global visiting you. My name is Satish Kutty. I'm the chair of the Education Committee of the British Hip Society. We bring you our next in a series of Global Reach webinar series. Today's topic is on periprosthetic fractures, very topical as is fairly common now because of the exploding number of cases that we see from around the world. On that note, I pass on to Anil Gambhir, our president, who's going to introduce the British Hip Society faculty. Anil.
Thank you, Satish. So it's a great privilege to be hosting ARCUS. We've built up a great relationship with ARCUS, who are our sister society this year and will be our guest society in Harrogate at BHS 25. This, as Satish says, is the latest in our Global Reach, and truly is a Global Reach webinar based focusing on periprosthetic fractures. We've lined up a star-studded host of faculty for you, and it's my privilege to introduce the UK faculty. So from Edinburgh, we have Chloe Scott. From Exeter, we have John Evans. And from Wrightington/Bristol, we have Josh Lamb. So I then hand over to Jeff, who will introduce the ARCUS faculty. Jeff.
Thank you very much, Anil. I'm Jeff Stambough. I'm one of the education committee members at ARCUS, and we're honored to be included in this across-the-pond discussion on periprosthetic fracture management. We have three excellent physicians who are burgeoning leaders in ARCUS who will join us today. We have Beth Gausden, who is a arthroplasty and trauma faculty at the Hospital for Special Surgery. We have Chad Krueger, who is a member leader at the Rothman Institute in Philadelphia, and we have Vinay Aggarwal, who is a rising physician leader at the NYU Langone School of Medicine.
That's brilliant. Thanks, Jeff. So we'll kick off with the first of the three presentations. So Chloe, could I ask you to share your screen?
Of course. Let's see if I can manage that. There we go. Is that sharing?
Perfect.
That looks good.
Perfect. Great. So I'm going to be talking about fixation of B2 periprosthetic fractures, largely around cemented stems, and it's an absolute privilege to be discussing some cases today with Beth, who I feel is my counterpart in New York, because we do pretty much the same jobs, I think. So what do we know about cemented stem related periprosthetic fractures? Well, there's two interfaces to think about. So you've got the bone cement interface and the implant cement interface, and that makes it a bit difficult to apply the Vancouver classification, for example, and determine whether a stem is loose or not. Composite beam and taper slip stems are quite different in the fractures that you get associated with them and the risk of fracture. So composite beams have a much lower risk of fracture, more bending type fractures, so more transverse type fractures, and often the fractures occur when the implant is loose, particularly at the bone cement interface. In contrast to that, taper slip fractures, they're much more common. They're typically long spiral fractures or metaphyseal split type explosions. But they typically occur in stems that are very well fixed at the bone cement interface. And of course, the stem is designed to be loose in the cement. So that interface is always going to be loose anyway. And the other thing to think about with cemented stems is cement actually provides pretty good fixation for screws. So I've said it's difficult to define what's loose and what isn't around taper slip stems. We do know, though, from modern research that most B-type fractures can be fixed, provided the bone cement interface is intact and the fracture is anatomically reducible. And actually, fixing these fractures is less morbid than revision when it's possible. And it appears that fixing B2s is safe into the medium term, and it doesn't give you kind of late stem loosening. So that's a brief introduction. Now let's dig into some cases, because that's what everybody is here for. So I've just got two cases kind of at either end of the spectrum. So this is my first one, 44-year-old lady, fairly good going osteoarthritis, I would say, in her left hip, undergoes a hybrid total hip replacement that she's very happy with, until she falls off her horse 5 months after her primary, sustaining this fracture. So Beth, you treat a lot of these, or maybe more around uncemented stems, but are you routinely getting CT scans on these to help you plan your surgery, or are you basing it just off these plain x-rays?
First of all, thank you guys for having me. And of course, honored to be speaking with you, Chloe, my counterpart across the pond. So yeah, I usually do, I take care of a lot of these, and you're right, we don't see as many taper slip cemented stems or cemented stems in general. But when I do see one, I get kind of excited because I agree with you, a lot of them are very amenable to fixation. I don't think you necessarily need a CT scan, but truth be told, I tend to get it on most of these because they come in overnight and it's just my routine. So the team has ordered it, especially if there's comminution. It's I think helpful to put the pieces back together. In this one, this looks pretty straightforward spiral. So it's just kind of fun to look at the three-dimensional view of it, but is it absolutely necessary? Probably not. I think if you treat a lot of these, you kind of know what you're going to get. Like you said, these tend to be more simple patterns compared to the uncemented or composite beam type stems. I do like to get a full leg a view. I have been fooled one time. I got sent over a transfer with just one quick shot of the hip, and it turns out it was bilateral interprosthetic femur fractures. So I feel like I was bamboozled in that one once, and I won't be fooled again.
Chloe,
Yeah,
do
so
you
yep,
CT
sorry.
everybody routinely?
No, I don't. So I CT the periprosthetic fracture that looks largely undisplaced, and you're not sure if it's just a GT fracture or just a calcar fracture, and you want to know if it goes down to the tip of the stem. So I CT those, so more the kind of undisplaced looking ones, and I occasionally CT the metaphyseal splits to see how comminuted they are. But if something obviously looks very comminuted on the plain x-ray, you're thinking you're going to have to revise it anyway, because technically it's a B3. So I don't routinely, and with this one I didn't. I was happy that I think there's a bit of comminution maybe at the tip below the stem, but it looks like that main proximal part is one piece. The stem's not subsided within that proximal part. And I think, you know, we've said that the key with these is really, was it well fixed? Was the stem well fixed at the bone cement interface before the fracture? And this one, you know, 5 months out clearly is. But if it's further out than that, then looking back, if you can, at the previous kind of post-op x-rays or previous x-rays pre-fracture to try and look at that bone cement interface, I think is really useful. So if you can get hold of previous x-rays, then that can be helpful to your decision making as well. So Beth, how would you plan to treat this? Would you fix it or would you revise it?
Yeah, I'm fixing these more and more. The one thing I'll say is I don't like calling these B2s, because I really look at it though, although temporarily the cement mantle's disrupted, if you put it back together, that's a stable stem. So I actually would call it a true B1, because it's not an unstable stem, or at least it won't be when we're done with it. And I agree with you. I think fixing it in this case is less morbid, especially in the setting of a well-fixed cement. You know, to put this back together, cable it, and then take out the stem and take out the cement mantle, that's just a much longer and more tedious operation and more time. Now, this is a 44-year-old female, but a lot of times these are 88-year-olds that the longer they're under anesthesia, the worse it is for them. So for me, I think this is a single plate fixation. I try to get as many screws proximally as I can. I like doing it in a lateral position just to facilitate. You could certainly do it supine, and there's millions of different plates out there. I tend to use an older, very straightforward locking plate without any bells and whistles, and I just shoot screws into the cement mantle, and those have excellent fixation.
Brilliant. Chad, you've got your hand up.
Yeah, so Chloe, Beth, you know, thanks for your education here. What is often discussed is, you know, well, is it really stable? And I think this one's pretty clear, right? But there's some that it's hard to really tell. In those situations, you know, do you think, look, just fix it, right? And it will kind of declare itself over time. If I think it's stable, I'm going to fix it. And if it fails, well, at least the fracture is back together and I can just revise it from that standpoint. Or are you more aggressive in those, saying, look, I really don't want to fix this. If it is loose, I want to do everything right away? Because I can tell you how I err, but I'm curious how what you think or what you want to tell the audience.
So we'll maybe, I've thrown in an elderly patient next, so we'll maybe discuss that in the next case, because I think it's not just the fracture pattern, right? It's the patient that it's attached to, and you do have to think about that in terms of the morbidity of your procedure. So I'll, if it's all right with you, Chad, I'll come on to that in a second, but that's what I did for this patient. So in fact, not even a locking plate, so a simple DCP. She's got good quality bone, decent distal fixation, enough proximal fixation. I think that's absolutely key, having got an anatomic reduction and compression of the fracture with cables. And you know, a high functioning 44-year-old, she could live without an extensive revision, if at all possible. So that's kind of what I did there.
So Chloe, you use the term enough proximal fixation. What is enough?
Well, so that's a good question, and I think you want as much large fragment fixation into the proximal piece. So I normally bend the top of a straight plate so that I've got some screws going up into the GT and up into the lesser. And I think I am worried in terms of some of the modern locking plates that people don't put the large fragment screws in. They just put the small fragment ones in, and they fail. Or they can fail because it's not enough proximal fixation, and I'll show one of those in a second.
Yeah, so I totally agree with that point. I think these newer plates that are coming out are certainly easier to put on, and there's less contouring involved. But I've seen a number of those types of cases too, where you really need like 4 or 5 or larger screws around the stem. And I would say, even in my mind, I'm only satisfied if I get 3 solid bites around the stem. And if you know, it's as I'm sure you know, over doing a lot of these, it's pretty easy to break off the screw heads if you're at an angle. So you don't have a ton of options, but if you take your patient and you can get creative and find those corridors. But I'm totally with you. I think the easy way out of using one of these periprosthetic fracture plates and like a 2-5 screw is kind of dangerous.
Absolutely. I mean, it doesn't work. I mean, so this is the kit that I have. I think you have to have a good plate bender. You need an anatomic reduction. I always have loads of Haygroves in there holding that while I put a load of cables on. And I try and maintain the vasogluteal sling where possible now. And I don't get a plate that goes up over the GT unless I really need that fixation into the trochanter. So here's a slightly different case that's maybe a bit spicier, but this time in a 92-year-old. So but a very well 92-year-old that lives independently, walks without any aids, and is very happy, or has been very happy, with her cemented total hip replacement until she fell and sustained this fracture. So are you still thinking the same, Beth, in terms of fixation, or do you think this is a bit punchier and you'd offer revision?
I think it's definitely punchier. I think it's doable, but I would look at it and I would probably revise this, just because there's too many pieces, and I'm worried that if I don't get the mantle back together perfectly, that I would worry that the stem's not going to be stable. But I mean, you guys have a lot more experience, you know, with this type of stem. So I am very curious to see what is the limit? What can you do with this? Because this is a painful revision, right? No matter what, you put it back together, you cable it back together, you take out the stem's going to come out easy, but that cement's not coming out easy.
Absolutely. I mean, it's a big undertaking, I would say, taking all the cement out, even though you've got a nice kind of osteotomy to take it out through. Right. And this lady's 92, right? Even if she's a good 92, that bone is not going to be fabulous. And if you're trying to chip all of that cement out and do an uncemented stem, that's got morbidity. If you decide to do a cement in cement revision with comminution, you can end up with cement coming out of the fracture, and then you have a non-union, or you chop it out and do a proximal femur, and that's quite a big operation for a 92-year-old. So in this case, I did use a fancy locking plate because I think this is a reasonable indication for it, because I want to get some better fixation in that proximal piece. So this is a ring plate that goes right up to the GT, but you can see I've used as many of the large fragment screws as possible. You can't just rely on the small fragment screws, especially as you're going into cement, because the torque is massive, and you're right, you can shear the heads off. So for better or worse, I thought in a 92-year-old, this was probably the lesser of the evils.
Looks beautiful. Did you have a tapered revision stem on backup?
Well, like I've got, yeah, I mean, we've got proximal femur on backup. We've got we've got everything on backup. So, and I realize that we're lucky for that. But I think you have to bend the rules a bit in these kind of super elderly patients. Totally I don't know how everyone else thinks.
So, Chloe, can I just ask you? So you've put here 48 hours to surgery. So that's great. You know, in the fractured neck of femur world, we try to get people to theatre within 24 hours. Do you think those same sort of rules should apply to periprosthetics as well?
I mean, I think they absolutely should. And I do think, well, we know from the literature, right, that if you're waiting for a revision for your periprosthetic fracture, you're waiting longer before you get your surgery, just because of the availability of the skill set, I think. You know, we're I suppose lucky in Edinburgh that we treat a lot of these, and so they tend to not wait so long for fixation as opposed to revision.
So your talk has obviously spurred on some questions. So I'm just going to quickly rattle through these questions. So Jeff, let's start with you.
Yeah, quickly. Just a point of reference here with these pre-contoured plates and the smaller fixation. I found the few that I've done, I'm not an expert by any means like you, is getting a screw or two in front and back to provide that kind of columnar support I have found to be really essential. And I've noticed you snuck some smaller wires up there first to get a preliminary reduction. And I found using the newer kind of smaller cables have been helpful to do that as well, to then allow you to kind of span it once you do that. So well done.
Vinay, you had your hand up?
Yeah, guys, I think, you know, really impressive cases. I think it brings up the point. We always talk to our fellows and residents. Well, Elizabeth, you brought up the point, is the stem stable? Well, I think one of our favorite questions is, how do you tell the stem is stable when you're intra-op? Do you violate the hip capsule, open up the hip joint, and test it from the top? And so in these cases, are you guys, obviously, it sounds like, making the decision, we're not going to violate the hip capsule at all first, we're going to fix it, see what happens, and therefore decrease our chance of instability? Is that kind of what I'm hearing?
That's my take on it. And I think from the American's perspective, you know, with a lot of ours are uncemented stems, that's the majority of the periprosthetic fractures we're treating. I really have a good sense going in based on the knowledge of the stem. So work at HSS, we've put in all sorts of stems here. Some have good track records, some have bad track records. And even if it hasn't subsided, for instance, if I know it's a stem that was put in the late 90s that's only got a little ring of metaphyseal coating, like, I'm going to revise that stem. I'm going to go for it. Versus like a Karai or a fully porous coated stem, or the modern stems that do get ingrowth all around. Even if it looks like a clamshell B2 type pattern, I kind of know going in that that's going to have some pot fixation in certain areas. So for an elderly patient, your point's well taken. I will not go in to dislocate just to make sure, because I think there's a lot of morbidity, particularly with a posterior approach, doing that and risking instability.
Okay, I'm going to give the last word to John, and then we're going to have to move on to the next debate.
Yeah,
John?
so it's a very quick point, really, and it's picking up off what you mentioned about time to theatre. And for me, the real principle behind this isn't actually time to theatre, it's time to weight bearing. And I think that's what we really need to judge ourselves on, is the core principle behind treating these patients with fractures is they must be weight bearing. Whatever we do, we've got to have the competence to get them up and weight bearing day one or day naught even. And so actually that metric of time to weight bearing is something that I've looked at as to whether we should be using that in our trials and in our studies.
Okay, John. So maybe that'll come out in your debate. So Chloe, I'm sorry we've had to curtail yours a little.
No, not at all.
So can I ask you to unshare? And John, do you want to share yours? And I'll hand over to Jeff to chair this.
Okay, so can you see my screen now?
Yes.
Yeah. Good. Okay, so my name's John Evans. I'm a hip surgeon down at the Exeter Hip Unit in Devon, and I work over at the University of Exeter as well, much like Josh, splitting my time between research and clinical work. And this case I've picked really is something to hopefully show that there are many more ways to skin a cat than just the exeter way, and hopefully that will come out in the discussion. So we picked a case here that back in 2019, a mobile and active 73-year-old fell down some steps and sustained an intracapsular hip fracture. It's a very common situation. He went on to have a bipolar cemented hemiarthroplasty, which is pretty much our standard. And I'll take this aside now to sort of talk about what we're doing in Exeter. So our standard approach for hip hemiarthroplasty now is what we call the SPARE, the Safe Piriformis and Internus Repair Externus. John Timpley's done a lot of work with this with total hip replacements, but this has become our standard approach for the hip team for hemis. And you can see here on the photograph on the right how those tendons really cover the femoral head, and you just can't see it at all. We feel it gives us a lot more stability, and it gives us an approach that we can go back to knowing where we've been. And in fact, you can see here from this video that was taken this year that when actually you move that head around, that repair is just, well, there is no repair because you've just left everything intact. So that is very much our principle now of treating these hemis. But anyway, sometimes they can be too stable, because if they fall over, that dislocation can act almost as a pressure release valve. And so in elderly bone, where they've already shown they've got weak bone from having a hip fracture, if that hip is too stable, sometimes you get the fracture. And that happened for this patient 5 years down the line when he fell. In fact, I think it wasn't downstairs. I think it was coming off a mobility scooter. And you can see here this sort of sleeve type fracture with dissociation of the bone. And really, this is something that we teach our residents, and it's a message that we very much get out that we're used to with Exeter, is this mind the gap sign. And so this has been published before. And if you're ever uncertain about looking for whether there's a periprosthetic fracture, looking for this thin black line around the medial calcar is a really good sign for anyone to see that there's highly likely to be a post-op periprosthetic fracture. And so we talked about CT earlier. We often find that our trauma colleagues will organize CTs before they come to us with these fractures. And often you can actually point, sometimes it might be diagnosis, and you can actually see it with this mind the gap sign. The other thing they'll often look for is, does it extend up into the GT? And our answer from the hip team is very much, if it's a fracture around an Exeter, you assume it extends up to the CT, whether to the GT, whether you've got evidence of it or not. And that tends to be how we treat ours. So I'm going to go back to this slide, and I'll get Vinay involved at this time. So what would you be doing in this situation? Because I imagine it's probably something different to what us cement-obsessed Brits are planning on doing.
Yeah, so first of all, thanks for having me, guys, from NYU's side of things and across the pond. It's a pleasure to be part of such an honorary panel and talk to a lot of young and at forefront minds on this field. One thing I'll tell you, Jonathan, is that mind the gap sign. I love that. It's a little bit different in New York with the subways. There's no gap between the population and the trains. And oftentimes, am I seeing, even though we're cementing a little bit more in the US, a lot of our residents will have the gap sign even in the immediate post-op. So we're trying to get better at cementing in America here. And we're trying to avoid that gap sign. But you're right. I think that something like this with a fracture around a cemented stem, we'd probably take this opportunity to say, this is already an ETO done for me, even if it's on the medial side. And I'm going to open this up. I'm going to take out this stem. I am going to violate this hip joint. And I'm going to take the stem out from the top and start chipping away the cement. And I can see there's some good cement bone interface here with, nice white fluff into the actual bone. So getting that cement out is not easy. I've had several, osteoporotic patients where you're trying to actually debond well cemented. Even if the implant cement interface isn't great, the cement bone interface is fantastic, and it's difficult chipping that away. But I think that's what a lot of American surgeons would do, is try to chip away at that cement, maybe use the fracture as an osteotomy, and try to get a long diaphyseal engaging tapered fluted stem down this. I think, that's probably the approach we would use. We've had pretty good results with tapered fluted. If you're talking to us about, 10, 15, 20 years ago with fully porous cylindrical stems, reaming those in elderly osteoporotic patients really bad with fractures, especially preparing and putting down the stems. But with tapered fluted stems, I think it's been a little bit of more of a blessing with these older patients. Still putting a prophylactic cable below the area of the fracture before I ream and before I implant my stem. But that's how I would probably approach this from across the pond here.
Yeah, thanks. And I think it's an interesting thing here. You talked about the cement mantle here, and often with us being so obsessed with cement and our technique and pressurization, that actually we we don't do ourselves any favors in the future. If you're ever having to try and remove the cement from something Graham or John Timperley has put in, then it's going to be a bit of a challenge. But this is what we went. So firstly, and this is a really important point, we believe very passionately in our multidisciplinary approach in Exeter, and we recently agreed that all periprosthetic fractures must be discussed in a multidisciplinary team before we go on to do them. And we even try to do that regionally as well. So SWAN is our regional group. And so we go on and we document that on Epic to make sure that everyone can be clear who was around, who agreed the plan, and we'll do that. And we're very keen on templating, and so we'll go on and found the original X-ray and went back to template exactly what we're going to do, which gives you a clue. And so this is what we did, essentially trying to restore that back as minimal violation as possible. You talked briefly about having to violate the hip capsule, and that's again what we tried to do here. Is my two principles are: one, I want to get that patient weight bearing as soon as possible, and two, I want to minimize any chance of dislocation going into the future. And if we can do that by fixation or revision, well, in this case, we obviously had to get in there, but we've obviously tried to keep that hemiarthroplasty to avoid further instability in the future. I can see, Josh, you've got your hand up.
Yeah, hey John, great case. Thanks very much. Just because a lot of people listening in on this might not do long stem cemented, and a lot of people worry about cement in the fractures, as Chloe alluded to earlier. What's your experience of this? Are you concerned about it? Anything that you do to reduce the risk of that?
So I think the key in the first instance is getting that anatomical reduction, which Chloe alluded to earlier. And if you can get the stem out and then you can restore it anatomically and get those cables round, then it's knowing that you're not going to get the extrusion of cement out into that fracture. And you can see that with this here, and I promise this wasn't a plant question, but when we do this technique, we have previously put endoscopes down, and you can see how anatomical you can get that cement mantle reduced before you go in and put your cement in. And that's obviously going to help prevent cement escape into the fracture. And you can see here that there is a very slight fracture line, but hopefully that is smaller than is needed. Jeff?
Yeah, this is very interesting. We do not see a lot of long cemented stem, cement and cement revisions here. And maybe we should, but the availability of such equipment is not always there. Is there techniques that you have? I mean, you said the endoscope, but of getting cement out, and obviously you have to prepare distally a little more, how to not cause more trouble during that long stem preparation?
Yeah, so there's a few techniques. So it's described pretty well in the Exeter HIP book. And if anyone's interested in getting a copy, it's available online, and all the proceeds go to charity. But the key things really is we have the availability of what we call the in-cement reamer. So that's an end cutting reamer. So once we've got it reduced, we can use that to then get down the canal and sort of ream up directly at the end, at the tip. So that's a useful bit of kit for us before we then go to open it up with Protect reamers or similar. So really getting it reduced, then using those end cutting reamers to give us the ability to break through at the bottom and get in a longer cement mantle, or get in the longer stem, is the key for us.
Do you send that plug down? The previous restrictor, do you send that down, or do you try to take that out, or?
No, that will. So the Exeter restrictor is made of PMMA, so it's bone cement as well. But if we can grab it and pull it out, we certainly will. So we'll ream through it, but if we can get it out, great, but not worry too much about it. And in this case, you can actually see that the surgeon that did this one, it wasn't me, has used stimulant beads as a cement restrictor there, just to try and block up that canal. But we won't necessarily go hunting for it. We'll just go straight through it.
And then how about version? If you're ever worried, is there any way to play with stem version in these? Because like you said, you try to disrupt the capsule and lead to less instability as much as possible. Do you ever downsize a proximal geometry?
Absolutely. That's another key principle of why we like our stems so much, is the ability to change the version. And we will obviously ream down to give us the length, but we'll also use, we tend to like a cebotome at the top end to get the cement out that we can see. And we'll open up that top end as much as possible to try and allow us to change the version. And one of the key things there is we have these stems on or the trials on the set that we know we can get the stem in before we start cementing. So we'll just keep putting a new one in, seeing how far we can change that version before we do it again, or before we re-cement in. And the key with re-cementing is, again, go in early. You want to make sure that you've got the cement in early, not leaving it really late. Otherwise, you could then be struggling with a long stem half in and half out. Moving on, so as you said, you can see our cement mantle there. 3 months post-op, it's gone on to unite. There's a very, very faint line seen there. You'll also notice I mentioned earlier the escape of the GT. We assume that GT is broken, whether we can see it or not. So we are now routinely putting a cable around that greater trochanter. Potentially this one here could have been a bit better if it had got under the left trochanter. But either way, it's holding it on, and we found that out the hard way. When in the operation, we just didn't think it was broken, and they come back at 6 weeks and they're upset with you with a limp.
Great case.
Now, just a very quick,
I just wanted to ask about your cement, because I know we have a couple minutes left here. It may seem rudimentary on the British side of things as far as what cement you guys are using and viscosity and everything, but on the American side, there's so many options that we are still figuring our way out, right? We're still on a training wheels, I would say, in the last 5 years, getting our registry numbers up. Thankfully, we're learning. But what would you recommend as far as redoing this with what type of viscosity and cement and how do you?
So for us, we normally just use standard simplex. We obviously have antibiotic impregnated for all of ours, so we'll have antibiotic with ours. We don't use Palacos. The benefit of simplex is that it is runnier for a bit longer, so it allows us a bit of play. And I wonder whether any of the British faculty that do use Palacos find that they have any problems when doing in cement revisions because it goes off quicker.
We use CMW1 cement in cement revisions. Mostly it has quite similar properties to simplex, and then you have that extended runny time where it can fit reliably in small gaps and you can get quite a nice thin extra mantle. How about you, Chloe?
I use simplex, I have to say. I think you would really struggle to do cement in cement with Palacos. It's just too set. You've got no options for the point that you want to go with it. So I would use a low viscosity for cement in cement, definitely.
And I think it's an interesting point you raised, Vinay, about cement and technique. And when Eitan Debbie and Ajay Premkumar were down in Exeter with us earlier this year, one of the things that they were most sort of struck by in our theatre when we were doing this was the speed and the efficiency that the cement was prepared. And sort of I asked for the cement to be mixed, and a minute later it was on the Mayo waiting for me to put it in. And I think that's the key, is just the number of times our scrub teams are preparing cement, and we're all just so comfortable with it. We even heat our cement in theatre so that it goes off quicker, and we're also confident of the way it goes. But that's an upshot of our standard elective practice. But I'd just like to finish very quickly. So this is not published yet. It's in the final stages of being put together. We've actually gone and looked at our cement in cement revisions for periprosthetic fracture and identified 93 cases. Patients, as you'd expect, to look the typical post-op periprosthetic fracture, and we followed them out up to 5 years. We can see that our mean operative times getting up to 3 hours, but they can be down to 1 hour and 10. And this mortality is of 1.1 at 30 days and 12 at 1 year is actually, I think, a very good reflection. Some of the work that you may have seen that Josh and I published in PLOS Med earlier this year showed that our mortality was actually similar or not on a par with that for hip fractures. So we're very pleased with this mortality. 6 out of 10 receiving blood transfusion, and we only had 6 patients with complications or re-revisions out of that 93. 3 for non-union, which you wonder are those cases where we've managed to get cement in the fracture. 2 for unrelated periprosthetic fractures, and 1 for stability. So really, that's the results of our survival for that series. So in summary, we think that cement in cement revision of the femoral component is safe. It has a decent survival in our patients. But again, you do need to consider revising the cup to prevent instability. Those 2 principles of mine are 1, time to weight bearing, and 2, everything you can to keep it as stable as possible, whether it's changing your version, revising the cup, or just leaving it as a lovely big hemiarthroplasty. Thank you very much.
Okay, thanks a lot, John. So we're going to move on to Josh and Chad. Satish, you're going to be chairing this one.
Thank you, Anil. Great discussion. There are some questions that have popped up. We'll come to that once we go through this last case. So, Josh, do you want to share your case?
Great. Yeah, thank you very much. Apologies, first of all, to Chad. I seem to have lost his edits with his proper titles, but it's a pleasure to have him with us today. He's a very experienced surgeon, fellowship trained, and working in the Rothman Orthopaedic Institute. I'm gonna talk about a bit of a difficult case, really. So this isn't one of my cases. It's just one I've come across over the years. And but it's really interesting because as many orthopedic surgeons as there are opinions about what should or shouldn't have been done. This is a case about a man in his 40s who's not had a great experience in life. He's a gentleman who misuses drugs and alcohol. He's got very bad bilateral OA secondary to AV end of the femoral head. He's in severe pain. He doesn't work, but it's maybe not entirely related to his hip disease, and he's failed conservative management. So, Chad, first of all, what are you going to do with this guy?
Well, I'd say he's not a low risk patient, right? Counsel him on that, but I mean, he's 40s, right? He needs a hip, right? Needs something to be able to walk on, right? I would not. I have no issue doing bilateral hips in patients. I would not do that on this guy. I'd rather prove that he can recover through one surgery first before doing bilaterals. And you know, I probably wouldn't be the patient I trust the most during the recovery process. Yeah.
Okay. So we've kind of touched on the fact that he's potentially slightly unreliable, and you know that just means the scope of problems you might encounter with this guy is slightly greater. So you need to be wary of that. He had a cementless total hip replacement done via DAA, which you know hopefully you guys will feel at home talking about with a collarless stem. Chad, any kind of comments about that?
No, I mean, I think it looks pretty reasonable from a hip standpoint.
Yeah, it's not bad. It looks pretty good, and he was happy with this. He came back. He had the other side done a couple of months later, as is pretty common in the UK with severe hip disease when the patient isn't really suitable for bilateral simultaneous. But unfortunately, a month after that, he then was found at the bottom stairs, inebriated, unable to walk. He'd fallen the whole way down a flight of stairs, no other injuries. Has this fracture, stem subsided, and so this is an early cementless fracture. So if we think about how this stem works, this stem is a fully coated HA porous coated stem. We need absolutely no movement between the stem and the bone for direct bone ingrowth, right? So something's happened here. The stem interface with the bone has defunctioned and it's moved. So what's your approach in the US with this?
I mean, whether I'm in the US or somewhere else, I would say the stem has moved. You know, it's acted like a log splitter down the femur. So, you know, I do a DA approach for this too, right? I go down, I put cables below at the base of the fracture site first, just to prevent further fracture propagation. And then I would remove the stem from the top down. I put more cables. I'd probably put another cable, somewhere in the subtrochanteric region as well, just kind of keep the tube together. And I would go to a taper fluted stem. That fracture looks like it's pretty long, be somewhere in the 240 to 300 range for myself. And, add another cable probably if I wanted to before that, depending on how things were feeling, and then move on with life. And that would be my treatment for this gentleman.
So just to be devil's advocate, so you've got a guy.
That's the whole point
here.
of the talk. I love it.
Yeah. So you've got a guy here who's a sitting duck for infection, and maybe it's not if, it's when, right? And it's easy. This is standard answer. I'm going to revise this stem, but really, there is an argument for saying, could we do less? Is that the right thing to do? And I think a lot of people think that at this time. They think, do I really want to instrument the top half of the whole of this guy's femur and kind of condemn him to a sort of panfemoral infection when he finally gets an infection, right?
Josh,
and I would say if this patient was 90, right, then maybe that's a different discussion, right?
Yeah.
And they don't really they just kind of transfer from bed to sofa, wheelchair around. Sure, right. I think someone like this, I'm going to the risk of infection is there to me, whether we do a revision hip or replate it, right, or try to do something else that's more fancy. I just want a solid fixation that I can build from there. That would be my goal of the case.
Anil?
Yeah.
Josh,
okay.
Let's bring Chloe in, Josh, So Chloe's advocating fixation in her talk. Chloe, would you fix this?
No, it's loose. So uncemented.
So was your hip. So was your
well, no, because this is uncemented and it's subsided in the whole bone. You know that it's loose, and that is a different game, I think. So you can't, the stem type and knowing what the stem type is and how fractures behave around those is important. They're not all the same.
It's and that's a great point, Chloe, because the whole philosophy of this fixation is different, right? We haven't got cement, which if you put back anatomically is going to completely fit the stem. We've got bone, which is crushed. The cancellous envelope is going to be misshapen. You're going to try and fix this back together. You're not going to get perfect stability. You're not going to get ingrowth. And I think that's a really important message to take away. But still, people get tempted to fix these and think, oh, if I just do enough, we might get away with it. But as we know, periprosthetic fractures, the outcomes can be horrendous. And just as much as this guy's got a long life to lead, he's got a long life to suffer as well if we get this wrong. So let's see what we did. So unfortunately, the decision was made to try and reduce the amount of instrumentation on this guy, and we saw the cables of hope around this guy's femur. So like we talked about this and how we're not really getting stability. We've got to. It's almost like half of your operation, Chad. This is at the point where you put in a proper stem and try and get diaphyseal fix, right?
Yeah, with maybe a cable or two less, but yes.
Yeah. So I guess another talking point is the diaphysis. We talked a little bit about CT before surgery. If you're a surgeon who's, like many surgeons around the world can use a modular taper fluted stem, revision type stem, you want to know your diaphysis isn't involved in the fracture, and a CT can be quite useful in that regard. We can see from the plain x-rays here that he's got a fracture in the diaphysis, which is a concern, and you can put a cable around it, but you're still probably with a cable around it, you're not going to get the scratch fit that you're hoping to get with the distal part of your taper fluted stem, right?
So I would devil's advocate that and say that, you put a cable or two down on the diaphysis and hold that fracture together. These stems are going to, in my experience, I use a monoblock stem, but it fits and sits just fine. There's not migration any more than I would expect from anything else. And I've had no issue getting those things to sit and fit, no matter how far down to the diaphysis that fracture extends.
And you don't.
The only difference being if it goes all the way completely down, like to the end of the metaphysis on the distal end, I'd back up with a plate. You know, depending on how that morphology looks distally.
Okay, so you don't see much subsidence when you've just cabled fractured diaphysis, something like this. You'd be pretty hopeful that it would work, right?
Correct.
Okay, cool. So so the key learning point for this is if you make the wrong decision, it will get worse. The probability of it going well shrinks dramatically. Okay, so unfortunately, I don't have the X-ray. It was a very long time ago, but the whole thing kind of fell apart. The guys leaving the ward, doing whatever in the streets outside, coming back inebriated. The whole thing falls apart because he's weight bearing on it. He's got very little pain because of the street drugs he's taking. So an attempt was made to fix it. So we've got a plate on the side. We've gone to plate the whole bone. We've got 8 cortices below the fracture, and again, just thin screws up at the top. You notice maybe not quite got the locking part of the screw head in, and so I'd say maybe not quite enough. I think, Chloe, you were talking earlier about how much is enough approximately. I guess if there was cement around the stem, you'd be a bit more confident with just like 3 good screws. But what do you think about this?
I mean, I think this is a prime example of someone using a fancy locking plate and not really, and still failing to get adequate proximal fixation. And in fact, it's even more dangerous with some of the plates where there's loads of small fragment screws and not very many large fragment options. And you get people putting cables around the plate and the bone and unicortical locking screws in the hope that that's going to be enough, and that is never going to work. So if you're going to fix things, you need to fix them well using sound principles. You can't just rely on the fact that you're using an expensive plate.
Yeah. So now if we think back to our original decision, the surgeon that was trying to do less to get more, they've actually ended up in a situation where we've stripped the periosteum laterally around the whole femur. Stripping periosteum in someone that could get an infection is just asking for more trouble. We've got metal inside and outside the bone. We've got a bone that's maybe in the worst position to heal. So, you know, the clock is ticking, and one decision just leads to another bad decision, and it will inevitably lead to worse outcomes. So, unfortunately, this construct starts to fail, and so 6 months later, because of the non-union, he gets some bone grafting and a second plating. We can see the old screw holes. It's been replaced by slightly longer plate with a bit more fixation. Proximally, we've now got multiple screws, and it looks maybe like this stem has started to integrate. So, you know, potentially more by luck than anything else, but certainly not a reliable outcome. Chad, any thoughts on this?
Geez. Yeah, I mean, I guess probably after it failed the first time, I would have said I probably should have just you know, revised this to begin with, and eaten it there. But you know, they went all the way down. Did they do an osteotomy? I guess you may not know, to try to realign that proximally. Yeah.
So I think it all tipped over because of an evolving non-union. Yeah.
So it's a hell of a reconstruction for what presents as a relatively straightforward problem, in my humble opinion.
Yeah. So you can see how, you know, relative to a standard case, a periprosthetic fracture just magnifies the potential for problems and magnifies the potential for harm for the patient. So I think just as you're saying, clarity and bravery to make the right call at the right time is really important. Okay. So what do we learn from this? So I think we learn to choose patients wisely. You know, we probably all agree that the first image with his terrible hips, this guy needs a hip replacement, right? But could we have done anything differently? I mean, I'm, you know, an advocate of a collar because of the risk of periprosthetic fracture, someone who's at high risk of falling because of drugs and alcohol maybe a collared stem might have helped him a little bit, who knows? But that's something to think about anyway. And early cementless fractures should be revised. We should take the big step, make it a solid construct, which is less likely to fail. And the key learning point is bad decisions don't get better. So don't throw good money after bad. Just don't do it in the first place. All right. Thanks very much. Are there any questions from that?
There's been a fair amount of questions, and Beth's been really running through all those with some fantastic answers. Also, there's the open questions. Panel's thoughts on strut grafts in addition to plate in fixation.
Yeah, I think if I'm worried about fixation, my first thought, and this is fixable fractures to Josh's last case, I 100% agree. A loose stem, you could have the world's best fixation and you're going to end up in catastrophe. But if I need more, I have a B1 that's right at the tip of the stem, I'll double plate that. I think the best strut is actually a plate. The times that I'll use cortical strut are actually usually in like congenital deformities where somebody just doesn't have normal bone stock. So I've used that a number of times with success in very unusual, short-statured people, abnormal anatomy, but it's not my first go-to. I think we know there's a high risk of infection. Putting dead bone in routinely in periprosthetic fractures probably not the best idea.
So Beth, is that in addition to a plate you use that?
Yes,
or do you use it as a plate? Okay.
I use it as my secondary plate, and especially in a lot of those people, it's like, the option is I could get like a small frag plate on anteriorly, but or a strut, and I'll opt for the strut in those cases. But it's not by any means. I wouldn't say it's my routine.
Yeah, yeah. I mean, from a research perspective, the vogue of using strut grafts kind of came out and was popularized a bit by Vancouver 20 odd years ago, and I think they've since stopped using it. Over a decade ago, right? Because of risk of infection and wound leakage. So I don't think it's a standard practice, just as you said.
Okay. Anyone else to add on to that? No. Okay. So there's one I couldn't understand. Is it important to have cement below the implant level as we do in primaries? Is this in relation to the second one or the first one? They haven't mentioned.
So so I think it was John. I think it was in relation to the X-ray of the revision with the tip of the stem poking into the stimulant beads at the bottom. And I mean, just from a writing perspective, the original method that we still do today is to use a bone block and put the tip of the stem in the bone block beneath the cement mantle. And just build it up from there, and that's been a successful approach for us in primary surgery. So I'd guess that the images that John's shown is that's going to be successful. So wouldn't worry about it.
It is difficult to get cement that far distal when you're using a long exter stem. They never look like a 150 stem. You never get that cement restrictor wedged and good pressurization at the tip.
Again, rudimentary point here from the American side of it, but do you guys have long cement nozzles for these cement and cement revisions? Because maybe NYU doesn't have them yet, but
yeah, we do have. So we tend to cut DARs down, and when we're mixing our cements, we'll normally cut it down for our 150 length stems. So they are quite long. But again, the problem we have is we'll often use a sort of revision type to get these long stems. So they're very long, but they're very thin, which then makes it even harder to get the cement pumped down and all the way to the bottom.
Right.
So yeah, we have the nozzles to get down there, but you do often end up with the appearance you've seen there. But the whole idea of the polished taper slip stem, the principle of it is that you're getting those hoop stresses from all the way down from the top to the bottom. So actually, it doesn't make too much of a difference. It's not the end of the world, as Josh says, if the tip of it isn't in cement, because actually you want to allow that controlled subsidence. So you want the tip of the stem to be able to subside a bit. I saw one of the questions came up, particularly about reducing the polished taper slip stems before and how much subsidence is allowed. And again, it's a case of if it hasn't, so that's what we're looking for on the pre-op X-rays and the CTs is how far has that stem gone down. If it's only gone down 1 or 2 mils, then you might be able to do a bit of a wiggle, a bit of a shake, and get it disimpacted and brought back up. But if it is too far impacted, then that's when you are going to struggle to get that in cement revision or fixation. There is one of my colleagues who swears blind by the toothpaste method, where he'll put cables around from the bottom to the top, and if you squeeze it from the bottom to the top, that solid lump of metal will be squeezed out by the solid lump of cement. But we love him still anyway.
Okay. On that note, Satish, are there any other questions?
Well, I think for Chloe, do you think we need a different classification system for periprosthetic fractures around cemented stems? Because this was originally designed for uncemented stems.
I think it's not useful, like the kind of traditional Vancouver. It doesn't help you with your decision making in the way that it does with uncemented stems. And I'm sure that we could improve on that because there's a lot of nuance. But then, you know, it would probably be more complicated and people would hate it because it was more complicated.
I should say on a slightly pedantic point that the classification system was actually developed on composite beam type stems like the Charnley, and but because composite beam stems work in quite a similar way to a cementless stem, they transfer quite well. But then Exeter and the attendees may well know it. They came up with the 2B or not 2B classification paper in the BJJ, which is an excellent paper. And it talks more about classifying looseness of the cement bone interface, which I think something Chloe spoke about and probably is more important than looking at the stem.
Brilliant. So on that note, I'd like to thank all the faculty. It's been a great privilege and honour to host Arcus at our BHS Global Webinar Series, and I'd like to thank all our faculty for their great presentations. Thank you very much. Take care.
Thank you.
Good night.
Thank you, guys.
Thank you, everyone.
Bye-bye.
Thank you.
Bye.